Dr. Paisley.
Thank you. Professor, can you assist us? When could symptomatic residents in a care home first access a test?
So symptomatic residents could first access tests from the outset in March, when we made decisions around how we deal with incidents and outbreaks reported from a care home setting, in keeping with how we might manage other respiratory infections such as influenza.
Sorry to interject, I think it's right on the 19th of March, the advice was the 3 most recent onset, and then that changed on the 25th of March, that if there was one resident who had tested positive, no further testing would take place. Is that right? And is that in line with the definition of an outbreak?
So the decision was made because of limitations in the capacity to do testing, which we had informed the system that we would prioritise for clinically suspected cases in hospitals. And there was a clear prioritisation matrix, but included in that was symptomatic residents in care homes.
You explain in mid-March, Public Health Wales gave advice regarding the testing of symptomatic key workers. And again, that focused on healthcare workers. When could symptomatic workers in care homes first access a test?
So the decision was made by Welsh Government on the 1st of April, I believe, for symptomatic care home workers to be tested.
To what extent do you think the advice from Public Health Wales in testing symptomatic residents and workers in care homes would have been different in March if that greater capacity had existed?
So the ability to positively identify a case obviously provides information about the infectiousness of that individual. But by then, there was already advice about isolation. So we'd moved from containment to delay on the 12th of March for anyone displaying one of the 3 cardinal signs at the time to self-isolate on the assumption that they would be positive. And we didn't have community testing, and people were advised to take that action.
And so if there had been greater capacity, would you have advocated for more testing at that time?
We would have advocated for more testing at a time when actually we were still trying to understand the nature and behaviour of the disease.
Can I move on then, please? You explain Public Health Wales was not asked to provide any specific advice in relation to the hospital discharge guidance of the Welsh Government, dated the 7th of April 2020. Is that something you consider Public Health Wales should have been consulted on?
As I mentioned earlier, any key policy decisions relating to the health of the population, we would want to advise on any matters relating to our roles and responsibility, particularly around infectious diseases.
Now, on the 24th of March, Public Health Wales was asked for advice to inform a letter to be sent to the care home sector. That was specifically to do with guidance about accepting admissions or returning residents. And can we please have on screen INQ 30336-353, page 1, paragraph 1. And this is an email dated the 31st of March between a number of officials within the Welsh Government. And one of those officials says, I'm trying to progress this with PHW on a daily basis, but not getting very far. It's extremely frustrating. Do you have any comments on that?
So this was a period of intensive care and attention to support the system in dealing with COVID. And we were having to deal with inquiries from professionals and managing incidents and outbreaks as well. And may I remind us that this was at a time before we had the Test, Trace, Protect system in place. So Public Health Wales was very much in the centre of the response. The contact with Public Health Wales from Welsh Government was made through several routes. Now, we did have an incident director rota, and we made that available to Welsh Government. So technically, that would be our route in to Welsh Government. But there were several routes created either through the enclosed settings cell or through individuals who had a role to play in testing, for example. So in this evidence, David Haben, who was then our head of operations in microbiology, was liaising with Welsh Government, particularly around key worker testing for social care workers. But when it came to a point when he was asked to comment on wider policy issues, he did remind Welsh Government of the routes into Public Health Wales.
One of the comments, I think, in this email is that the Welsh Government was struggling to know with who to contact at Public Health Wales about which subject, and you've briefly touched on that. Was there a confusion about who should be contacted within Public Health Wales?
So in our opinion, there wasn't a confusion. We had a clearly identified incident director rota, and that rota was made available to Welsh Government.
Thank you. That document can come down, please. And we don't need to go to it, but on the 29th of March 2020, Tracy Cooper responded to a concern that had been raised by an Assembly member about care homes accepting new admissions without testing. And her response was new residents should similarly be assessed for signs or symptoms of COVID-19 infection, and those affected isolated as appropriate. If new residents do not have any symptoms prior to admission, there is no value in testing for the presence of coronavirus. The test is designed for patients with symptoms, and therefore we don't routinely test new residents prior to admission. This is something we touched upon earlier. At this stage, could the tests pick up somebody without symptoms?
So the test was intended for use in symptomatic patients, and therefore designed for use as such. And so all our validation procedures in our labs would conform with that requirement. And it was that requirement that enabled those products to be marketed in the EU. So we very much adhered to that intended use, and so were unable to predict with any accuracy how it would behave and perform when used on asymptomatic individuals.
So but that's not going anywhere near as far as saying there's no value in testing, is it?
I think,
saying you didn't know doesn't mean there's no value.
I accept that, and I think Dr. Tracy Cooper sought advice when she emailed back to the inquiry. I think in hindsight, we should have accepted that there was some value in testing, but I think it is true to say it was designed for symptomatic patients.
Thank you. On the 2nd of April, the UK government published its UK government guidance on the admission and care of residents in care homes. You explained that this led the Welsh Government to ask Public Health Wales to produce equivalent guidance for Wales. Was there a request by the government that should mirror the England guidance, or did Public Health Wales feel able to amend it as necessary?
That was the request, and there were also comments about a more comprehensive guidance akin to the one published by UK government. And so on the 6th of April, I believe we sent back some comments on the proposed Welsh guidance, indicating areas where we needed it to align to existing Welsh Government policy and guidance, and highlighted those areas where new policy needed to be in place.
So Public Health Wales then did feel able to comment on where changes may be necessary?
Indeed, and we felt that we wouldn't want to change the public health content because we understood the process that it went through for the publication in England.
Just exploring this in greater detail, please. A draft of the care homes letter that Public Health Wales had been asked to advise upon was circulated on the 3rd of April, and that letter, I think, was 3 pages long. Can we then please have a look at INQ 000520925? And on page 5, email at 1709, the response from the Welsh Government Albert Heaney favours a more comprehensive approach in terms of the advice which is to be issued to care homes. He will not be signing the proposed letter for issue today. And then the response from Public Health Wales. In the meantime, we will do some further work on pulling together a Welsh version of the PHE guidance. Would that be helpful? Government response was, yes, please. We would favour more comprehensive guidance covering the relevant issues in one place as far as possible. So at this stage, what was Public Health Wales's understanding of what it was meant to be producing? Because there had been a request for a letter and the guidance. So was it both?
So it was to inform the letter and also produce the guidance. And, the request came in on a Friday, and by Monday, as I said earlier, we prepared a document with track changes and comments to highlight those areas that needed to align with existing guidance and areas where new policies needed to be developed.
And just before we look at the 6th of April, in your opinion, did the need to advise on both of those simultaneously stretch Public Health Wales in any way?
I think the letter itself would have related to the guidance. So for me, that was probably the easier part of the request. The more challenging bit was the guidance document itself, because it needed to align with policy, which wasn't necessarily in place at the time.
If we can stay on this email then and scroll up to page 1, and you've helpfully confirmed that the guidance was shared, the draft guidance, on the 6th of April. And there was a comment from Margaret Rooney of Care Inspectorate Wales. And her opinion was, in general, my feeling is the tone of this guidance is very much about care homes accepting people being discharged from hospital. It may feel very much like we are saying you must take people. I feel this would be more accepted if the tone was more about, here is some guidance on how to care for people in this period, and as part of that, you may be admitting new people from hospital. And Tracy Cooper's response was, there is an increasing level of urgency. It's taking quite a time to agree whilst care homes are desperate for guidance. Now, that document can come down, please. The following day, Margaret Rooney said she was not happy to brand this a CIW as it currently stands. And whilst it was appreciated that it mirrored the approach in England, she said, we feel we need to pause and reflect on whether this is the right approach for Wales. The response of Public Health Wales was the guidance had been well thought through. The risks of not getting it out now are greater than getting it out as it is. And my question then is, was anything changed in the guidance following the comments of Care Inspectorate Wales?
No, and that comment was repeated the following day on the 8th of April, and the guidance draft that we sent through was approved that evening by Albert Heaney.
Reflecting back on the concerns expressed, do you think any of the concerns of Care Inspectorate Wales were valid and worth raising?
I think the whole issue about hospital discharge testing was an area of interest from the outset. Care homes clearly had a duty of care to their residents and were concerned about incursions of COVID into a vulnerable population. And that was manifest through trying to make sure that any policies relating to discharges from another high-risk setting, hospitals, wouldn't pose a threat to care homes, and that is perfectly understandable. However, it was at a time when we were really clear that isolation provided an additional control measure, so that in the case of any positive or infectious individuals, we were able to also, through that measure, control transmission in that setting.
The final guidance was published on the 9th of April, along with the letter to the care homes. And as you've confirmed, the public health content was taken directly from the Public Health England guidance. Do you agree that there was a delay in publishing that guidance in Wales? And if so, what do you attribute the delay to, and how could that have been avoided?
I think, as I said earlier, the delay was partly about ensuring the alignment with existing guidance, that they weren't contradictory, alignment with policies that may or may not have existed in Wales at the time, and also differing views that you've heard and expressed earlier about hospital discharge testing.
Can I just go back to one of your answers first? I'm sorry to keep interrupting. You felt that isolation provided an additional control measure, but I've heard that isolation wasn't always possible in many homes where, for example, residents have dementia.
And that's the real life situation that we had to, take into account. Technically, theoretically, isolation is a good control measure, but practically speaking, in care homes, particularly smaller care homes with highly vulnerable populations, it is difficult. I accept that.
Thank you, my lady. A few follow-up questions on isolation. The guidance published did not, in fact, recommend isolation for all patients discharged from hospital, did it?
So there were circumstances where isolation wasn't deemed to be necessary after a period of time for those people who had been diagnosed with COVID. And that period of time was accepted as 14 days.
So if people were not being tested and they were asymptomatic at this stage, how would providers have known that they had COVID and been able to care for them safely, particularly without recommending isolation for all discharges?
So we had always advised that isolation following discharge from a high-risk setting would be advisable, but accepted that it wasn't always practical.
So is it the case then that Public Health Wales advised that that should be in the guidance, that it was advisable to isolate everyone, or was that perhaps an oversight?
I mean, I don't have access to the document to be able to verify that, but our approach had always been to isolate as a precaution for anyone whose status wasn't known.
So then, from the time that the decision was taken on the 13th of March to expedite discharges, would Public Health Wales's view have been that where possible, every discharged patient to a care home should have been isolated?
That's correct.
Can I move now, please, through to mid-April? And can we please have on screen INQ 306177081 and page 2. You explain in your statement that Public Health Wales first became aware of the Welsh Government's change of position in relation to testing all patients on discharge through an email on the 15th of April 2020. And we can see in this email it says, CMO and Albert Heaney want a revised approach to testing in place ASAP, which will include testing on hospital discharge to care homes. Do you agree that's a clear policy instruction to Public Health Wales to update the guidance to reflect that change?
So policy decisions are communicated in a variety of ways, whether it's a ministerial statement, whether it's a statement by an officer such as the CMO, or whether it's in an email request such as this. We didn't take this as a definite policy decision, but clearly we took this as a request to consider an approach to testing for hospital discharge to care homes.
We can also see here there was a request for more general testing for care home residents and staff. So in effect, 2 requests. If we can scroll up onto page 1, please. Giri Shankar says, if we were to follow the English guidance, we certainly do not have the testing capacity to meet that revised requirement. Was that in relation to the testing on discharge, or was that in relation to the more general testing?
I think it was in relation to the more general testing, because the use cases and the requests for increased testing was coming through to the team as multiple requests. So this was one of many requests for testing. And at this time, there was an allocation of the assays for us to use our high volume testing equipment that was already in place to a certain number per week. So we had to take those constraints into account. I guess what we didn't do at the time was calculate the estimated increased activity on testing should this policy be in place. And that's something we could have taken stock of from the DHSC guidance, which talked about 6% increase in activity.
What you say in your statement on this point is Public Health Wales did not have access to the numbers of hospital discharges to care homes, but anticipated this would be within the manageable number for the testing capacity. So is it then Public Health Wales's position that you would have had capacity to test everyone on discharge, and specifically when from?
So hospital discharges were not a known entity up to that point, because what was happening was directed by policy. Now, if then there's a requirement for testing to admit someone to a care home, we didn't fully understand what impact that would have on testing capacity. So I think monitoring hospital discharges would have been helpful to understand how that would impact on our testing capacity.
So would it be helpful then in the future if Public Health Wales did have access to the number of people being discharged in this sort of scenario?
Yes, and an impact analysis about how a policy decision would affect that.
Who would have provided that information?
I think we would look to the NHS Wales system as a whole to model that, and would look to Welsh Government to provide the analytical input to that as well.
Moving then to the 16th of April, which is the day after the email we've just looked at, and there was a meeting attended by Public Health Wales and the Minister for Health and Social Care, and you say that he presented a different position on testing based on Chief Medical Officer advice. Can you help with what the different positions were?
So my understanding is that there was an issue around testing asymptomatic individuals in care homes that had a different position taken, that it was conveyed that there would be no place for testing asymptomatic individuals. Now, if necessary, we can feed back in more detail around those differences.
Can we have on screen, please, INQ 304999632? And this is a summary note of a meeting on the 16th of April. And on page 2, Andrew Jones of Public Health Wales writes, "We will need a clear policy steer or instruction from Welsh Government colleagues, notably in areas where current scientific advice or evidence may not be consistent with actions." And then at action 3 on page 3, it states Welsh Government policy officials verbally outlined a clear request or policy instruction from CMO Director of Social Services and Integration for the testing of non-COVID-19 patients prior to discharge from hospital to care home setting. And if we can then please go to page 1, bullet point 1. The first bullet point noted by Alison Mashon of the Welsh Government, several references below to not having clear steer or instruction from Welsh Government. This has been provided in emails to Public Health Wales from both Marion and I. It was reiterated at the meeting this morning. However, Andrew kept saying that from a meeting he'd attended yesterday, this was not Vaughan's position. So at this stage, do you agree that there had been a clear policy instruction regarding the testing on discharge?
So, as I indicated earlier, the kind of policy position and how it's conveyed can take several different forms. I think in Public Health Wales, we were probably expecting something more formal than in an email, in the body of an email with a request. Now, had it said Welsh Government is making a policy decision on this to test patients before discharge, we would have taken it as read as such. So implicitly, it could have been that it was a policy decision, but it wasn't explicit.
To avoid these issues arising in the future, what would Public Health Wales need to see that communicates a very clear decision?
In an ideal world, we would work towards a policy decision, to be given the opportunity to provide advice to inform that decision from a specialist viewpoint, and to be able to work with the system to ensure that as and when the policy decision was made, the structures and processes would be in place to support that policy decision.
Can we please look at some of the other bullet points here? Bullet point 2, it says, it was agreed that there should be testing for people who had been in hospital for a non-COVID-19 condition, and that a negative test result, presumably before discharge, would enable return to the care home. Again, a couple of caveats here. The tests are not cast iron, and so there should be a further 5 days isolation on return to the care home. Can you assist us with the clinical reasons for the 5 days of isolation, please?
So the 5 days isolation was based on the known knowledge of the behaviour of the infection at the time, which is that by 5 days, most people who would have been incubating the disease would have developed symptoms.
And bullet point 3, Public Health Wales's position was that testing for people who had been in hospital with COVID-19 was not necessary before discharge. And the logic, I believe, was that they would not be infectious after 14 days, but may still be testing positive. Can you help us? Was there any guidance already in place in Wales that said someone who had been admitted to hospital with COVID-19 would only be discharged after 14 days had passed?
So there was nothing in place at the time. And our clinical teams who dealt with many of these patients were also being asked for advice in the hospitals around people who persistently tested positive who weren't able to be discharged, although they were clinically well. And there were discussions about how do you interpret the test results. And over time, there were advisory notes that the technical advisory cell had produced in relation to testing. And that culminated in December in a position where, by looking at more detail of the test result, and the CT, the cycle threshold value, was then used as an indicator of infectiousness. So anyone with a CT value of over 35 was then deemed not to be infectious. And that helped with people who were persistently positive.
If we then go to bullet point 5, the question of where else people are safely discharged to if there is potential for them to still be infectious is being discussed and planned separately. And I think that this is discussion of step-down facilities or sometimes called designated settings. Was that the first conversation Public Health Wales is aware of about those settings?
We weren't involved in the planning for the step-down facilities at a local level. Our focus on, managing outbreaks and the surveillance of infectious diseases remained.
From a clinical perspective, was that a sensible precaution, and should that have been brought in any earlier in Wales?
I mean, in light of the policy to discharge only on the negative test from a hospital to a care home, this made sense because then you had a facility that was able to care for people who were still waiting for a negative test result, who were clinically well and didn't need hospital treatment. And at the time, hospital facilities were very, very stretched.
Thank you. That document can come down, please. There was a further meeting between Public Health Wales and the Welsh Government on the 17th of April. And again, your statement says Public Health Wales had still not been advised of a decision to formally change the testing policy. At this stage, was there anything preventing the Welsh Government updating and publishing the hospital discharge guidance?
Not as far as I can tell, and that subsequently came on the 22nd of April.
So is it your position then that that didn't need to wait for these conversations with Public Health Wales, and that decision could have been implemented by the Welsh Government itself on the 15th of April?
I think that's probably correct. I mean, we were in a position where we needed to understand the evidence base and the rationale. We were in a position where the guidance document that was branded under Public Health Wales would normally have an evidence basis for it. So to not have the co-branding with Welsh Government and the regulator put us in a position where we were producing guidance that, didn't have a scientific basis for it. And you will note the later evidence that we did publish about the impact of hospital discharge on care home outbreaks.
Following that through then, if the Welsh Government had taken that policy decision and published updated discharge guidance, I think you would agree that Public Health Wales probably did have the capacity to do that testing from the 15th of April.
I believe so.
Moving on then, please, to the 18th of April 2020, and Public Health Wales, along with the other devolved health agencies, attended an incident management team meeting with Public Health England, and this was to discuss the results of the Easter 6 study. And that study concluded that symptoms were poorly predictive of infection and therefore a poor trigger for control measures. You explain the significance of that work, and you explain that Dr. Chris Williams convened an internal Public Health Wales meeting on the 18th of April to discuss the implications of the report and ideas for a Wales approach. Can you help us with what the outcome of that meeting was to discuss the impact on Wales?
So the impact of having evidence in the UK of asymptomatic transmission in a vulnerable population in the care sector meant that we needed to look at our policies and guidance about, for example, making assumptions that asymptomatic individuals were not infectious. And therefore, that led to a need for assessment of all the evidence and the guidance that we had in place at the time, and working very closely with Welsh Government on policy decisions.
Can I then move on, please? And 2 letters were sent to the care sector on the 22nd and 24th of April 2020 by Albert Heaney and Frank Atherton. Now, an updated draft version of the care home guidance was circulated by Public Health Wales on the 27th of April 2020. And we don't need to go to the document, but there was an email from Public Health Wales which says, "We have reframed this as public health guidance, and therefore it is more generic to cater for the scientific view rather than the policy position." Can you explain what's meant by that, please?
So that was to stick to the public health aspects and guidance that we thought would be helpful for the care sector. That included a wider remit than just a focus on hospital discharge testing.
The view of the Welsh Government was that the draft guidance was inconsistent with the letters that had been sent to the sector, and that it didn't pick up on areas such as global testing of residents and staff testing. And you explained that there still hadn't been a policy agreement within the Welsh Government at that stage to introduce those measures. And there were some further concerns about the letters to the sector that you've raised, for example, on the intention to introduce asymptomatic testing. And Public Health Wales was aware that there was an intention to introduce that, but didn't know the timescale. Did Public Health Wales receive copies of the letters from the 22nd and 24th of April?
I don't believe we did.
Would it have been helpful had you received them?
It's always good to have a heads up of the detail that's about to be announced to the system. In fact, on the 22nd of April, the distribution list didn't include Public Health Wales.
On the 28th of April 2020, there was an email from Alison Mashon to Albert Heaney and Frank Atherton, and she said there were various meetings that have been held to go through the issues over the last week or so. I want to draw your urgent attention to the significant difficulties we are having in making headway with Public Health Wales. In fact, it has become impossible. Was there then a disconnect at this point between Public Health Wales and the Welsh Government?
The disconnect wasn't that we weren't meeting regularly with them. I think the disconnect was a difference in view around some of the decisions.
You explain it wasn't until the 29th of April that, from Public Health Wales's view, there was a conversation and an email exchange, which was helpful in agreeing a position that guidance should reflect policy decisions. We were able to make clear through those conversations that the policy needed to have been made, i.e. approved, and clearly communicated to Public Health Wales before changes were made to our guidance. Do you think that Public Health Wales did enough proactively to get clarity?
Probably not explicitly. I think, when we had an assumption about how policy announcements were made, we didn't expect it to be in an email. So I think having that clarity confirmed in an email on both parties helped us to then understand that, guidance follows policy.
And what was different to the email on the 29th of April as opposed to the emails we've looked at that suggest there had been a clear policy steer?
So again, this is something of interpretation, whether something was a clear policy decision that had been made and had been communicated widely, that we then had to prepare guidance to align with the policy decision.
The final version of the updated care homes guidance was published on the 1st of May. Could you briefly summarise, if you can, having looked at what we've been through, what were the main factors for that delay, and do you accept that there was a delay?
So it was at the time when we were also asked to prepare the operating model for Test, Trace and Protect, to work out how the health system in Wales would respond to the ongoing COVID pandemic, to look at the response to and management of incidence outbreaks, to look at surveillance, and to look at how we would support the various sectors. So that was a huge piece of work, and that was commissioned on the 22nd of April. So alongside this, we were also looking at how we would take forward this request on policy changes around testing for hospital discharges. And you will recall that we were still operating the enclosed setting cell, who had the main remit around developing guidance for the care sector. And they were also dealing with inquiries from the care homes themselves. So there was a lot of activity at the time. And with fast changing policy decisions, we had to ensure that everything aligned and was consistent, not just with guidance within Wales, but also guidance across the UK, such as the UK IPC guidance.
You briefly touched upon earlier the establishment of the internal guidance cell, which was in July 2020. Did that help with the production of guidance and clarify any of the earlier issues experienced in March and April?
It did, because this was a dedicated resource that was there to produce guidance documents. And that further became more formalised the following year with the establishment of the guidance cell, which was directly part of the health protection response in Public Health Wales.
So would the internal guidance cell have a role to play in a future pandemic then?
That's a lesson we learned in the pandemic and implemented.
Touching then, please, on the impact of the discharge. And I know Public Health Wales undertook some work in this area, and it's Public Health Wales's view that there were a number of different pathways of care homes arriving into care homes in March and April. Does any of the findings of Public Health Wales need to factor in the fact that there were a limited number of tests undertaken in March and April? And does that change the findings in any way?
So the study was undertaken during the period between February and May, I believe, and looked at all hospital discharges into care homes, irrespective of test results. And clearly, for part of that period, there was no testing done for hospital discharges. So we accept that it would have included some who were negative and some who were positive. And it is, we're not able to know retrospectively whether that would have made a difference. If anything, it would probably have diluted the impact that we identified. We did a further analysis looking at a longer period from February to December 2020, looking at the impact of a positive care home worker on an outbreak occurring in the care home subsequently in the 14 days, and found that to have a risk of about 3-fold increase compared to no statistically significant increase from a hospital discharge.
A few short questions about May testing decisions, please. And on the 1st of May, which was the same day that Public Health Wales published the updated guidance, you explained that you became aware through media reports of the Welsh Government's intention to change its testing policy. Is that the intention to test asymptomatically that we discussed earlier? So Public Health Wales knew it was an intention, but not the timescale?
That's correct. And this was to offer a wider testing in care home settings. Up to then, it was symptomatic residents and workers.
Did Public Health Wales advise on that policy?
We did not.
Should Public Health Wales have been asked to advise?
We should have been asked.
And similarly, that policy was then updated on the 16th of May 2020 to include a wider number. Was Public Health Wales asked to advise on that change?
I believe we were.
I just have one final substantive topic, please, to explore with you, and that's in respect of visiting. At paragraph 38 of your statement, you outline that an advice note was provided to Sir Frank Atherton on the 19th of July 2021, and it's right that Public Health Wales provided a number of formalised advice notes, and this was regarding visiting to care homes. One of the conclusions was that complete closure of homes for an extended period when there are cases among staff or residents is no longer proportionate. Was Public Health Wales then of the view that prior to July 2021, there were circumstances when complete closure for an extended period was proportionate?
I think the context is important here. Clearly in July 2021, we had got over the worst of the second wave from the Alpha variant and were preparing for what we might consider as endemic COVID. And I think it was right for us to make that comment. Now, up to then, clearly it was a different period of activity and COVID transmission in the community. So we were always agile in our advice to the circumstances around the epidemiology.
John's campaign have raised in their statement to the inquiry that there was insufficient clarity on the meaning of end of life for the purposes of visiting. Was Public Health Wales involved in the definition of end of life? And if so, do you agree that the definition was unclear for the purposes of visiting?
So our advice was on a pragmatic level with the intention to reduce the incursion of COVID in a care home. And so whilst we were not responsible for defining end of life, we would help care providers interpret what would be end of life, always with that principle of protecting other residents from visitors.
Do you think there could have been any improvements to the way that end of life was defined or how care homes were interpreting it that may have assisted?
I think this is a really difficult area because clearly end of life is not something that we had any means of assessing on an individual basis. So those who provided care would know best, and the clinicians looking after them would be the best people to advise on what end of life would be, given the circumstances that we had.
And then just one final question, please. Other than anything we've already covered in your evidence, are there any particular recommendations that Public Health Wales has learned from its own experience with the adult social care sector that you would urge this inquiry to consider?
So I would reiterate the point I made earlier about Public Health Wales being the single sole source of notifications and surveillance of infectious diseases. The second thing is to reiterate the importance of high-quality infection prevention and control in care homes, and that the regulator and responsible persons should ensure that care homes have the policies and procedures necessary to maintain high-quality IPC, and that training is available to staff. And clearly, there are bodies around education and training that can support that. And thirdly, we recognise that we could have engaged much earlier with the care sector in order to get the real lived experience in our response.
Thank you, my lady. I have no further questions. I believe there are some core participant questions.
Thank you, Ms Paisley. I think someone's gone down the wrong way. Mr Stanton.
Thank you, my lady. Good afternoon, Professor. I asked questions on behalf of the COVID-19 bereaved Families for Justice Cymru. I'd like to ask you a question about the decision of the Welsh Government on the 15th of December 2020 to allow discharges from hospital to care homes with low-level positive tests. And you touched on earlier this issue when you mentioned a cycle threshold of 35 or above. Professor, acknowledging that a low-level positive test meant that the risk of infection was reduced, do you accept that this did not mean that there was no risk and that there were uncertainties about the period of infectivity?
I think evidence and our experience of infectious disease changes, especially when it's a new one. And that changes based on our understanding of how it has behaved and understanding of the natural history. And no infection is the same in two individuals. So there are many factors to interpret what a test result actually means. But based on our understanding of the natural history of the disease, a 14-day period from the last detected symptom or the date of onset of symptoms gave us a good understanding that if they were asymptomatic and that period of time had lapsed, then they were unlikely to be infectious. And then corroborated by a weekly positive test gave us more assurance that that individual wouldn't be infectious to others.
Do you accept, though, that there remained a risk?
I mean, technically, you could argue that with a positive test, albeit with a high CT value, there may have been a small risk. I'm not able to quantify what that risk would be, but based on an understanding of the disease and how it behaved, we believe that risk to be very small.
Do you think you can rule out any connection between this policy and the surge of infections and deaths that occurred in care homes in Wales in January 2021?
We can't rule anything out in terms of the impact of this policy. I'm not sure that we undertook any specific studies in relation to what we now know as, the impact of the alpha variant in the autumn of 2020. So I'm not able to comment on that.
Thank you. Can I come back to the balance of risks that you mentioned earlier? Given the extreme vulnerability of care home residents, the way in which infections spread rapidly within care homes once seeded, and the inability of care homes to deal with infection through IPC, which you've just mentioned in your concluding remarks, and also the inability of care homes to care for residents with infections. Do you think, despite what you say about there only being a small risk, do you think the balance of risk was correctly determined in this instance, particularly given at the time the known increase in infections in care homes?
So I think taking hospital discharge testing in isolation, this was one of many other potential incursions of COVID in a care home. And we know about the impact of care home workers working across multiple sites, and also the provisions for workers as well that meant that they might have to work in order to have a steady income. So there were many factors that we understand now that played a part in the transmission in care homes, in addition to the very different environment that is probably more conducive to transmission.
Do you think the fact that the Welsh Government was prepared to take the decision it did at this time say something about the prioritisation of care home residents?
So if we compare the discharge testing policy in Wales with England, on the 15th of April, where in England hospital discharge testing was recommended, but a negative test wasn't a requirement for admission to hospital. I think Welsh Government took a policy decision over and above, and therefore that technically would have protected residents in care homes.
I'm sorry, Professor, but with regard to the December decision?
So with respect to the December decision, again, I don't have any evidence to suggest whether or not the change in advice around a positive test would have resulted in more cases. But I don't have that information.
Thank you. Thank you, Milady.
Thank you, Mr. Stanton. Ms. Morris. Ms. Morris is just there.
Questions on behalf of the COVID bereaved Families for Justice UK. And just one short topic, please, and it may well be a clarification. Ms. Paisley asked you about the chronology of advice to the public from Public Health Wales. You touched on a moment ago as well with her the advice to the Chief Medical Officer for Wales on the 19th of July 2021. And you say in your statement that was, if you like, the first specific and direct advice provided to the CMO for Wales that directly addressed management of COVID in care homes. So why did it take until July 2021 for that first direct and specific advice to come from Public Health Wales to CMO?
So let me clarify one thing. From October, we formalised the process for providing advice notes to the CMO. And by July 2021, we introduced a single point of contact within Public Health Wales with a managed inbox to deal with requests and commissions for advice. So the list of advice notes that we have compiled for the inquiry includes examples of where the advice was specific for the care sector. But throughout the pandemic response, we were providing advice to the technical advisory cell, to the CMO directly throughout the response.
Is this part of the internal guidance cell that you talked about, sort of centralising and formalising advice from July 2021?
Yeah, the guidance cell was there to publish guidance and seek advice from our subject matter experts in order to produce that guidance. The advice notes would have not just been focused on guidance, but might have asked us for advice on particular policy considerations.
That's clearer. Thank you. Thank you, Professor. Thank you, my lady.
Thank you, Ms. Morris. Mr. Straw. Mr. Straw's over there.
Good afternoon, Professor. I represent John's Campaign, the Patients Association and Care Rights UK. You accepted earlier and in your statement that Public Health Wales should have engaged much earlier with the care sector to better enable you to understand real lived experience of those on the ground. Would you agree that this engagement should have included with representatives of people drawing on care and their supporters, because they are best placed to understand that real lived experience?
We like to think that service user experience is part of the requirement for us to understand how best to deliver a high quality service. It is one of the foundations of how we run a service. So, a short answer would be yes, absolutely. We would need service user experience as part of that engagement.
You earlier at paragraph 115 of your witness statements, you describe a weekly group chaired by Improvement Cymru from March to June 2020 for care home managers to meet and discuss priority issues for those living with and caring for people with dementia. In those meetings, were representatives of people drawing on care and their supporters also invited?
I believe not. And just to clarify, the cwtch is the Welsh word for hug or cuddle. So it was there to support the care home sector, and it ran for a year. And the evaluation after that suggested that this was very welcome by the care sector. To my understanding, I don't believe users or their representatives were involved in those discussions.
Are there mechanisms in place, or do you think there should be, to ensure that people representing those drawing on care will have a voice in meetings in future, in particular in a future pandemic?
I think it's a vital part of how we develop our response and service on an ongoing basis. So, yes.
And in terms of those meetings regarding priority issues for those living with dementia, can you recall what were the priority issues for people living with dementia during the pandemic?
So my understanding was that it was a peer support group. So care home workers, managers could exchange their experience of how they manage particular situations. I don't have the details of what the key priorities were, but it extended beyond IPC guidance, which actually our health protection teams would be more familiar with. But the cwtch project came out of a wider initiative to support quality improvement in the care sector that Improvement Cymru, which was then a directorate of Public Health Wales and now part of NHS Performance and Improvement in Wales, had established a 3-year programme, and the cwtch project came out of that.
Final question, which is about data collection. You earlier indicated that you consider there should be a comprehensive single source of data collection, including on rates of COVID infection for those in care. Would you agree that it's also important to record other non-COVID causes of death, mental and physical illnesses, and other factors, so that the impact of restrictions during a pandemic can be better understood?
And we did have a system for collecting COVID deaths, but underlying all this would be a need to understand mortality as a whole. And our wider data function gives us access to monitor those deaths. But that's a system-wide responsibility.
And non-COVID deaths?
So non-COVID deaths was something that we didn't have primary focus on at the time of the response, but clearly there are other mechanisms for looking at that through the Office of the National Statistics, who was a much more comprehensive source of information around that.
Okay, thank you very much.
Thank you, Mr. Straw. Professor, that concludes the questions we have for you. Thank you very much for all the help you've given to the inquiry, and thank you for my new favourite word.
Thank you.
I think you'd like us to take a break now.
Yes, please, Madam.
Casey, before the next witness.
Thank you.
Very well, I shall return at 3:15.
All rise.
Ms. Paisley.
My lady, the next witness is Christina McNee.
I swear by Almighty God
that the evidence I shall give
that the evidence I shall give
shall be the truth,
the whole truth, and nothing but the truth.
Fred, you got the last spot of the day today, so sorry if we've kept you
That's
waiting.
all right.
Good afternoon. Thank you very much for attending the inquiry today and for providing a statement to this module dated the 16th of April 2025. You are the General Secretary of Unison, and in the statement you explain that the three of the affiliate unions of the Trade Union Congress, Unison, GMB and Unite, have a particular presence or interest in the adult social care sector. Is that correct?
It is.
The TUC has 48 member unions, and it exists to support those member unions and the members of those unions. Is that right?
It is.
The statement you have provided has been co-signed with representatives of both GMB and Unite. Is that right?
Yes.
Unison is a public services union whose representation includes around 157,000 members in the social care sector. GMB and Unite are both general unions. GMB represents around 50,000 members in the social care sector, and Unite similarly represents a broad range of workers in the sector. Is that all correct?
Yes.
Turning then to the devolved nations, TUC Cymru sits within the wider TUC, but leads on matters which are within the powers of the Welsh Government and matters which are wholly specific to Wales. And as you explain in your statement, the issues faced in England in the social care sector were largely mirrored in Wales, but your statement in some places draws out the specific Welsh experience.
Yes.
Both the Scottish TUC and the Irish Congress of Trade Unions are independent from the TUC. However, you explain that the TUC works in partnership with its sisters in the devolved nations, and this is formalised through the body known as the Council of the Isles.
Yes.
To what extent was there communication between all four groups on matters related to the pandemic response and the impact upon the adult social care sector between March 2020 and the end of June 2022?
Thank you. Before I answer that, would it be all right if I just say I want to pay tribute to all of the victims of COVID and their families, the impact it's had on their families, and also to all the workers who died during the pandemic and the impact it's had on their families, and on behalf of my union and the TUC. Turning to your question, there was, so the TUC General Council pulled together all of the unions, which are the 48 affiliates, and there was discussion between, mainly between the Council of the Isles, but particularly between the TUC in Wales and the Scottish TUC. So there's a lot of probably more discussion and correspondence between the Scottish TUC and the Welsh TUC and the main English TUC, with a sort of side discussions more taking place with the Irish ones.
And in your experience, to what extent were the trade unions across the four nations observing the same sorts of issues in regards to the adult social care sector?
My union is, from a Unison point of view, we are a UK-wide union, so we have members in Scotland, Wales, England and Northern Ireland, not in the Republic of Ireland. Other unions have them in the Republic as well. I think Unite have members in the Republic. Certainly from my experience, the issues across the four nations were very similar. There was next to no difference. There were some bits where obviously we were having a different elements of a relationship with the different devolved administrations, so different level of partnership working or more informal discussions that would take place with the political leadership in certain parts of the UK. There was quite a big variation across the UK in that sense.
And we'll come on to some of those topics, but for the workers on the ground, it was similar issues and concerns.
Very similar. I wouldn't say we were able to distinguish any major differences.
From the TUC's perspective, please could you give a brief overview of the biggest concerns faced by the sector going into the pandemic, so February, March 2020?
Yeah, so going into the pandemic, It was we were dealing with the legacy issues or the ongoing issues of the problems within the social care sector, which was a lack of cohesion, very little central information, no central control at all. Certainly worse in England than anywhere else, but not particularly great elsewhere across the UK. And a sector that was had high vacancy rates, had high numbers of staff on insecure work. So there would be a high number of staff on 0 hours contracts or who were agency workers, who didn't get paid even the minimum wage because of the travel time issues. That is, they don't get paid. Many workers don't get paid for travel time. So it was a sector that was in a lot of flux, high turnover of staff, and they're just really difficult to get a grip of it, and no partnership working at national or indeed local level most of the time. There were
perhaps if I can pause you there, because I'm going to actually come on to that topic next. So you explain in your statement, prior to the pandemic, DHSC did not include trade unions in regularly convened national forums dedicated to the care sector, including forums focused on the workforce, and any engagement was on an ad hoc basis. Yeah. And during the pandemic, you explain a number of groups were convened by the UK government, and you explain that unions were involved from their inception. Is that right?
Yeah.
Was that seen as a positive step, given it was a concern going into the pandemic?
Yes. I mean, as soon as the pandemic hit, I think there was a recognition that there needed to be something urgently done to try and deal with the issues that were coming up from the social care sector. And that included what was happening on the ground in terms of getting access to PPE, etc. And one of the ways to do that was to talk to the union representatives. So it was definitely an improvement to have some kind of partnership or some kind of meetings taking place.
And do you think that those groups were convened early enough in the pandemic?
I think they came about mainly because of a lot of pressure from us. So we'd started, from us being the trade unions, we'd started writing to government departments to say there's a major issue, because almost immediately one of the things we saw within my union was we started getting calls and contact from care workers on the ground coming through different routes within the union to say there's a major problem. So it was one of the first things when we went into lockdown. One of the first things we started to get was calls coming through from our regions to say there's a major problem in the care sector. And we then wrote to governments to say, you need to talk to us about this. So it came about through pressure from the unions.
Could I ask you to slow down?
Sorry.
It's all right, no, it's the end of a long day for the stenographer, so between us she might despair.
In your statement, you also list the forums in which the TUC Cymru engaged with the Welsh Government regarding the adult social care sector. And similarly in Wales, no structure had existed prior to the pandemic. And I think it's right that Unison and organisations within the TUC Cymru had been calling for a forum for some time. What were the reasons given for those calls for a forum being denied prior to the pandemic, briefly?
Certainly from the UK government, one of the key reasons they were giving us was there was no way for them to control what happened in the social care sector. It was predominantly provided by the private and voluntary sector. So it was about at least 80% of it was provided through those sectors as opposed to through public services. And the central government's, the Westminster government's response was always, it's nothing to do with us. We don't really cover social care. That's dealt with at local level.
And I think in Wales there was the creation of the Social Care Forum, and you say it became the route through which unions lobbied for and informed key policy decisions, including statutory sick pay, risks associated with mandatory vaccination, issues to do with workforce retention, pay rates. And when you refer to that in your statement, you say in contrast to the UK government, this was established in Wales. So were there any gaps in the groups set up by the UK government that something akin to the Social Care Forum would fill?
So there was no overall social care forum partnership arrangement with the UK government. There was a series of, even after we'd gone into lockdown, there was a series of different groups set up to deal with specific issues, which I think is laid out in paragraph 22 in the report, and you'll see them listed. So these were set up because it was when there was an issue, they would set up a group to deal with something specific, but there was no overall involvement. And we had, I think it was mainly Unison that sat on them, if I recollect correctly. I think there might have been one or two where maybe GMB might have had a seat on it, and a lot of that was because we jumped up and down about it. We did it through the TUC.
And just pausing there, have any of the groups that were set up by the UK government or the Welsh government been retained since the pandemic? And do you still have representation on them?
No. So once the pandemic was over, not until recently, there has been a group set up in the past year, which looks at pay and conditions and other issues within the social care sector. But after the pandemic ended, there was no continuation from the government at that time that carried on.
And in the event of a future pandemic, what would be the value of these groups with representation from the trade unions?
Well, having a standing group, I think, would make a significant difference because you'd be able to deal with issues on a much quicker basis. My big worry up until fairly recently has been if the pandemic happened tomorrow, we'd be still pretty much in the same position when it came to social care. As I said, within the past year, there has been another social care group set up with the current government, which is looking specifically at issues, workforce issues. So this is a group that's been set up to look specifically at pay and conditions and for the social care workforce. And it's already met several times, and it involves unions and employers and providers.
If I can then move on, please, to some specific meetings. On the 31st of March 2020, members of Unison attended a DHSC workforce meeting, and the first of those meetings had been held on the 19th of March 2020. But can we please have on screen INQ 301199097, which is the 31st of March meeting? Thank you. And this is a summary note of that meeting taken by a Unison representative. And the first paragraph on page 1 discusses the Bringing Back Staff initiative. And the note goes on to say 7,000 nurses had expressed an interest in returning to work. However, only 150 expressed an interest in returning to social care. And then at the end of that paragraph, a comment is noted, perhaps we could encourage members who come under this umbrella to consider working in care or nursing home settings. Can you help with whether that was something the TUC or respective unions were trying to actively encourage, and if so, how?
So we were involved in the discussions about trying to encourage staff to come back to work. And I think our view was if we could say to them, specifically think about coming back to social care. To be honest, I'm sorry, I can't remember offhand whether we then sent anything out specifically to ask them to come back to social care. I'd have to go back and check that.
Are you aware if the governments were taking any active steps to encourage people back into social care?
I'm certain that they weren't.
On the next paragraph, please, it says care providers say they have been unable to key into the initiative and register their need for more nurses through these structures, and that there was a clear feeling that the needs of the care system vis-à-vis nurses are not registered or recognised. Can you help us with what is meant by unable to key into the initiative, please?
This was very much an NHS initiative, and there was very few areas where the NHS and care providers would be together. Even in a situation like this where you think they would have been, there was hardly any forum where that would happen.
And in fact, that's a feeling that's expressed in this email, is that there is a growing disquiet from across the group, as with the volunteer initiative, that the care sector was being sidelined Who was doing that sidelining?
Well, government officials, would have been the ones that, when they were setting up these groups, this was very much an NHS initiative to begin with, and it just felt that there was constant push, certainly from us as the union, but I'm sure from I was in touch at the time with some of the provider organisations too, that they were expressing their frustration about the fact that it was almost impossible for them to be taken seriously by the Department of Health, because they were just seen as not a big player when it came to the social care, or more than that social care was very much an afterthought.
If I can ask you then to reflect and looking forwards, if there was to be a future pandemic and there was consideration about such an initiative, how could care workers practically be encouraged back into the sector?
Well, one of the key things would be you'd have to look at the way care is set up at the moment, the way the care service is set up. So just now it's one of the worst paying, worst set of conditions, the worst anything when it comes to the workforce happens in the care sector. Most staff are on minimum wage, or as I said earlier, sometimes even less than that if you're a domiciliary care worker. Their conditions are appalling, so they don't get paid sick pay, they get paid the absolute minimum sick pay, they have minimum annual leave, many of them are in 0 hours contracts. So to bring them back to a workforce where they're contrasting themselves with an NHS workforce, which is a whole different set of terms and conditions, where staff are treated with dignity, and by and large with dignity and respect, they're seen as valued members of the workforce. That just doesn't happen in the social care setting.
Could I pick up on something you said, was that this was initially an NHS initiative? Perhaps would a practical example be if it had been a joint initiative from the outset? Would that be something practically that could have been done?
It would have been if there was some... The part of the problem you've got is that there's no central lead in the care sector. So there was no employer's body that was one employer's organisation. There was no one provider organisation or one commissioning organisation. The nearest you had to anything that would represent the workforce were the 3 unions that are part of this. We were always happy to discuss these things. But even for us, the difficulty we had then, and to an extent even now we still have, is there is no recognised employer's body or umbrella organisation that represents the care sector, and the government certainly did not represent the care sector. They very much took a hands-off approach to the care sector.
I'm going to move topic, but could I possibly ask you just to keep your answers a little bit shorter,
Sure.
just because we have a number of topics to get through. Thank you. Can I move on to personal protective equipment, please? And staying with this document, in the third of the longer paragraphs, there were concerns raised about PPE on the 31st of March. And it says, we've had a lot of members raise concerns about the lack of it. Provider representative bodies expressed a real anger that hardly any PPE is reaching social care providers and it's all being diverted to the NHS. It was reported that some care workers are having to resort to wearing marigold gloves. From reports you're aware of coming in from on the ground, just how bad was it for those providers without access to PPE?
It was shockingly bad. I can't emphasise it enough. We set up our own hotline, a call line for the workers who were Unison members, and within the first morning that we set it up, we had 1,000 calls. Within a few days, we did 4,000 calls. 90% of them were from people who work in the care sector, and they were desperate calls. So it was an appalling situation, and the distribution of PPE, as far as I could tell, was being made up on the hoof. There was no thought had gone into it.
Well, in fact, there was a concern raised in this email that there was no coherent approach to PPE or the distribution or access or coordination in local areas, and providers were getting increasingly frustrated. And focusing then on the lack of a coherent approach, what sorts of things were providers reporting that the difficulties being caused about the lack of coherency?
So it was a mixture of reporting from providers, but also from our members and our officers on the ground as a union. So we would be sending officers in to talk to the care homes about what the problems were. So we were getting a mixture of information from a mixture of sources. And it was no proper system for distribution from any central resource. Some were resorting to trying to buy their own from different providers. Even in the union, some of our local branches, so as a union we're made up of branches, some of our branches were actually buying PPE from wherever they could get it to distribute to the members. And they were going to workplaces to give them PPE and give them masks and gowns and things.
And so in terms of what a good coherent approach would have looked like, can you help us with what the TUC would want to have seen in terms of the organisation?
Yeah, so there would have to be a central distribution system, the way there was for the NHS, which is, one, they'd have to know where all the care homes were and what kind of services were being provided in those care homes. Where were they getting their PPE initially? You'd have to find a way to direct the care homes to actually, and the care providers for domiciliary care, to give out PPE in a certain way. That took a long time and was very confusing to try and get that during the pandemic. I'm not sure we ever got it right, but it certainly wasn't. Certainly the first few months it was a nightmare. So that would have to be getting thought about now. You'd need things in place now where they had mapped what the care sector looked like. They had worked out what the regional distribution centres would be like, or who would be responsible for it, whether that was going to be local authorities or it was going to be some NHS providers. But there'd have to be a system put in place, and it should be in place now, because if there's a pandemic tomorrow, as far as I'm aware, that system's still not in place.
That document can come down, thank you. Unison, in fact, wrote to Mr Hancock and Mr Johnson directly on the topic of PPE in March 2020. And can we please have on screen INQ 339480? And in that letter, page 1, paragraph 3, please, it says, we know that considerable efforts are being made to solve the logistical problems associated with supply and distribution of materials. Can you help us, please, what the considerable efforts that were being made were at that point?
Well, I think they were trying to deal with them mainly about the NHS. So this was about trying to deal with delivering PPE to the NHS. We'd seen on the news all the attempts the government were making to try and find PPE, get it delivered, etc. The big problem we had was that wasn't getting through to the care sector at all. And they were always the last to be considered when it came to how you would distribute PPE.
Now, as this module is focused on the adult social care sector, can we please scroll to the bullet points at the end of this document? And if this is purely related to the NHS, please say so. But were any of these bullet points applicable to concerns in the care sector as well?
All of them would have been applicable to the care sector.
So in that case, can we look at a few of those, please?
Yeah.
These are suggestions of Unison about how it may operate better. And the first thing is to note that this is a request that these are put towards instructing employers to take measures. And focusing on some of the suggestions, the first one, explain clearly to staff the scientific evidence employers are using when they make decisions about the provision and use of PPE. And so from your perspective, could some issues have been addressed simply through better communication of why decisions had been taken? Yes, and
can I give you an example? Because I wasn't the General Secretary at the time, but I was the Assistant General Secretary in charge of our negotiations and bargaining, and I was directly involved in managing the staff who were working with us and being involved with government departments. And one of the discussions I had was with, I think it was someone from the Health and Safety Executive who was telling me that there was advice up online about how care workers should access PPE, put it on and dispose of it. So I was saying to them, one of the big issues we keep getting asked is, what PPE should I be using in different circumstances, and how can I put it on, take it off safely and dispose of it safely? And I was assured that it's there on the website. And when I came out, while I was on the call, I was looking up the website. I couldn't find it. And I said to him at the end of the call, I've just looked this up and I can't find it. And I'm not a busy care worker. I'm sitting at home doing this. I said, do me a favour, when the call ends, go on and see if you can find it and come back and tell me. And he did get back to me and he said, no, you're right, I couldn't find it. Then when we did find it, it was absolute gobbledygook. And
so visibility and simplicity then would be something.
I don't know who it was aimed at. It might have been aimed at scientists, but it certainly wasn't aimed at care workers.
And one of the other recommendations at the very end is about suitability and effective training being provided to the sector. And is that something that would have been equally as applicable to the care sector?
Absolutely. I mean, these were care workers who were having to deal with patients either who'd been long-term in the homes or were discharged from hospitals, often with COVID. These were people who were going in every day to deal with the elderly, the confused, people with learning disabilities, and there had been no training on what what was appropriate for each of those different kinds of settings that they were dealing with.
And do you have any suggestion as to who would be the responsible body for delivering such training?
Well, I think it all goes back to the fact that there is no central department that seems to have responsibility even now for those kinds of issues. So I don't know whether that would be, whether there needs to be some kind of national care service. We've been calling for this for some time. A national care service that has responsibility for a range of things, not just the pay and conditions of the staff, but actually what happens in that service. And if we had something like that, that was like the NHS and had that kind of parity of responsibility, parity of esteem, whatever you want to call it, that's an organisation that could look at how do you train staff, how do you make sure that they've actually got the information necessary to deal with the patients that they look after, and to deal with issues around PPE, which are still there in the sector.
That document can come down, thank you. You talk about the establishment of a PPE task and finish group. Did that assist things at all?
It helped in that it meant I think I was the only trade union person on that. If that was, I get confused at the different ones. I was on one and one of my colleagues was on another. On some of the others.
Could you give us possibly an example of how your representation on that group helped?
So again, it's because we were able to because we were running all sorts. We had the helpline running. We were running surveys of our members. We've got about 400 officers across the UK who were working directly with local authorities, who would be able to, and who would be able to contact us and say these are the major problems we were coming up against. So we'd set up a system in Unison that said to the staff, start recording and logging all of the issues so we could see themes that were arising so that we could raise them. So that gave me and the other staff who were sitting in these bodies direct, in real time almost, information that we could feed in, and that's what we were doing. And it sometimes conflicted with the information that those groups were receiving from providers or commissioners, because they were saying this guidance is out and we're implementing it. And we would be saying, well, if you are, it's not filtering down to care workers because that's not the information we're receiving.
In respect of groups such as this, would it have been helpful if there was more clarity about how what you were expressing was actually being taken forwards by the government?
Yeah, that was another issue. I mean, we were quite often a lone voice, in fact, usually a lone voice on these groups. And whilst there was, I don't mean to disparage everyone who's on the group, there was a lot of people who were very sympathetic to what we were saying. But that wasn't always necessarily what was actioned. So the issues we were raising were not always actioned.
And just my final question specifically on this topic, I'm not going to ask for it to be brought up, but within one of the documents, there's a suggestion by a colleague of yours that within PPE guidance, it might have assisted to have an accompanying FAQ document. Yeah. Is that something that would assist in the future, and particularly if people from the sector were involved in developing it?
Definitely. FAQs, but also one of the other suggestions I remember making was, why don't you make little short videos, which I think eventually they did, of how you put on PPE and how you take it off and dispose of it, just as an example.
And very briefly touching upon the response in Wales, were the concerns that were being raised in Wales very similar to those in England, and would the suggestions for improvement be the same across both nations?
Yeah, very similar, hardly any difference.
Moving on then to concerns over pay, please, for the sector. And you explain that members in the sector were reporting that low levels of sick pay were putting pressure on them to return to work when they should be self-isolating, something which Unison had raised with the DHSC in April. And I think it would be fair to say, was that a UK-wide problem across the sector as well?
Yeah, a massive issue.
And you can explain that in England, concerns around pay continued right through into 2021. How significant was the issue of pay when it came to those crucial matters such as self-isolation?
So this was massive, and there was a direct correlation eventually came out when you looked at the information about infection rates, that those homes that weren't paying sick pay were more likely to have a higher rate of infection. And that, I'm sure it's in some of the figures, some of the papers that are here. So there was that correlation, and we always suspected there would be. Why wouldn't there be if you had staff who were turning up to work? Because to not turn up to work meant you had absolutely no money, because these are low-paid workers. There is no safety net for them. There's no money, usually no money in the bank to tide you through over the next few months, as it were. You have to turn up to work to make money.
And from the perspective of Unison and the wider TUC, is it your opinion that this would have been obvious from when in the pandemic that this would have been an issue?
From day one of the pandemic, I think we started raising it certainly quite early on in meetings, that this was a major issue and it would be a driver of infection if you were saying if staff felt they had to turn up to work rather than take time off once they started, if they were being told to self-isolate or they were unwell.
Were there sufficient forums that this could be raised to give the governments examples of on-the-ground experience of how this was impacting?
Yeah, it was one of the key issues that came through the hotline that we had set up. Initially it was all about PPE, and then it started to go on to I can't afford to take time off, or I've been pinged and told I need to self-isolate, but I can't afford to self-isolate because they weren't getting any money.
Mr Hancock told the inquiry, now this is in respect of pay to reduce staff movement across different care homes and domiciliary care workers. He told the inquiry, personally, I would ban staff movement between care homes in good times as well as in pandemics, because communicable diseases kill people in care homes all the time. You could easily rejig the employment arrangements so that if 2 care homes each employed people part-time and then each of them could take a fewer number of people full-time, it would lead to a decrease in flexibility. That's absolutely true. But you could still work in one care home on a 0 hours contract and do something else when there weren't any hours coming from that care home, for instance. And finally, he went on to say, but why should we have care home workers on 0 hours contracts anyway? Do you have any comments on how something like that would impact on workers in the industry? So is it practically achievable and something the TUC would support?
So a large number of care workers will have more than one job, whether that's in 2 care homes or more than 2 care homes, or they might be a care worker and a domiciliary worker, or they might work in a care home and work in a supermarket. I mean, it's very common to have more than one job. And I think banning them outright like that without, in a system that is so fragmented as it currently is, I can't see that working. And I can't imagine that this would even be considered if you were talking about, if you said this would apply to nurses or doctors who worked in 2 different medical centres. without thinking through what the compensation would have to be for those workers. But somehow when it came to care workers, no consideration was given to whether they should be compensated for this when it was proposed at the time. And I remember raising it vociferously at meetings with people saying, these are already low-paid workers and you're basically telling them you're going to ban them from working anywhere else.
Can I ask you about the Infection Control Fund, please,
Yeah.
which was announced in May 2020, and you explained that was as a result of campaigning and lobbying by Unison. Was the Infection Control Fund a fit-for-purpose answer to what Unison had been lobbying for?
So we had pushed very hard to say you're going to have to find a way to fund people to be able to stay off sick and get paid some kind of sick pay. And we're pleased when initially that seemed to be the answer, but no, right from the beginning when we saw that this was actually going to be more flexible than we thought it should have been, and therefore it would be, although there was a set of criteria that had to be met, it wasn't in our view sufficiently robust to say this is primarily to be used for paying staff when they're off sick, and therefore we were getting reports that large numbers of home care providers and care homes weren't using it for that purpose. And we were constantly going back at these meetings to say that, we'd be getting told, oh, it's now in place, it's now working. And we'd say, no, actually, we've just done a quick survey. And we were getting great, people were responding to the surveys at that time. And we were able to come back and say X percentage of staff are still not getting paid sick pay. So it wasn't working. And we told them that the day they launched it, that they had made it too lax.
If I, again, I'm so sorry, just because we're pushed for
it's fine.
time, if you could if you can keep your answers shorter. Funding in Wales, it's right that there was a scheme to enhance statutory sick pay. Did the schemes work differently, and was either one of them better in your view?
They did work differently. I think the Welsh one was a bit stricter in terms of the saying that it had to be for paid sick leave. The English one was not robust at all, and there was no proper monitoring of it. And afterwards, when we asked them to at least come back and tell us what it had been spent on, that was never done.
Can I ask you please now about unequal impact across the pandemic? What were your organisation's concerns, or what were you hearing of about the impact of the pandemic on ethnic minority members of the workforce?
Yeah, very quickly after into the pandemic, it became apparent that black and ethnic minority workers were being disproportionately affected by it. We started to get a lot of reports on this, and we started doing our own, not until perhaps a bit later, but we did our own survey of black workers within. Sorry, I should explain that in Unison we use the term black to encompass black and ethnic minority workers. So we did a survey of our own black and minority ethnic members to ask them about this, and it was obvious from the figures as well that we were getting through. Once they started monitoring, there was race monitoring taking place in terms of deaths and numbers of people getting COVID, that you could see very quickly that it had a massive impact on black communities.
In Wales, the BAME COVID-19 advisory group was convened to advise the First Minister on disproportionate impact, and a number of recommendations were made. Was there an equivalent structure set up in England?
No, not that I'm aware of. Not that we were involved in.
And do you think that the recommendations of the group in Wales were something that was acted upon by the Welsh Government, and is that an example of good practice?
Yes, I mean, the fact that the Welsh Government took this more seriously, that they had set up a group and that they had recommendations to follow, was definitely something that should have happened in England.
And the inquiries also heard evidence about the All Wales COVID-19 workforce risk assessment tool. And is that something that should be implemented in the event of a future pandemic, or something like that?
There should be a risk assessment tool that applies to all staff. And again, the care sector is so unstructured as opposed to the NHS that you absolutely need a proper risk assessment methodology toolkit. to make sure it has an impact in that sector, because a lot of the time you're talking about small care homes or even a large care home or domiciliary care group. It's very different from a large hospital in the way they would structure, and they'll have their own head of health and safety, for example. You won't get that probably in a care home.
Can you give a brief overview, perhaps, of how the risk assessment tool would have helped?
So having a risk assessment tool that was easy to follow and understand, that employers are familiar with, that unions could have gone in and said, have you followed this? That workers would have been familiar with it. I think it would have helped the managers in the sector as well to be able to deliver, better care for their workforce if they had something simple and easy to follow.
Can I move on then? And one of the things you mentioned in your statement is the possibility of having a register of social care workers for England. And you explain that that's something that does exist in the other nations of the UK. Why would registration or having a register of care home workers been of further assistance in England? And are there any examples of how that did help in the devolved nations?
Well, I think once you've got that, it means you can see there is some then central control. You have some central information about where staff are. You have some central information about what their training is. Have they had some minimum training? In England, there is nothing like that. So, and there's such a high level of turnover among the workforce that I think it must be incredibly difficult to keep control of that. And given the kind of work, the nature of the work that care workers do, for me, it's almost unthinkable that you would have people going into individuals' homes or giving close personal care to people in a care home where there isn't a register and that there isn't minimum standards of training available to people. I would argue that having that surely must help with outcomes in any kind of setting.
Can I please move on to the topic of testing? And I'm going to ask for a document to be brought up on the screen, please. And it's INQ 30119063. And this is a note of a meeting on the 30th of November 2020. And again, this was with the DHSC. And on page 2, second paragraph, please. It discusses the issue of testing, and it says, after many months of us raising the issue, they are at least finally capturing data that at least allows them to see what employers are not testing staff properly, even though they are not then really doing anything with that information. What was the issue, if you can help us, with testing that Unison had been raising?
The fact that so many, although they were saying that they were testing staff, the information that we were getting back was that that wasn't actually happening on the ground. I think we've submitted some evidence that shows the percentages. People were coming back and saying to us, I think there, April 2020, 99% of all care workers in our survey had not been tested for COVID-19. And even in May 2020, large numbers of care workers still hadn't been tested for COVID. And so it was an example of what I was saying earlier, that we're getting told one thing by central government or by the DHSC, yet the information that we were getting back from care workers on the ground disputed that. And we were having to then present this evidence to them and say, well, we've just done this survey that shows this is not happening.
So the data that's referred to about the data they are finally capturing, what was that data?
So they were trying to capture how many care homes, care staff were being tested, and they were getting regular updates. I mean, I think every week we were getting updates on the percentage of staff that had been tested and how frequently they'd been tested.
And what would Unison want to see the government have done with that data?
So what they should have been doing was to check whether this was, what was the level of infection looking like? Were there any particular areas where that infection rate was particularly high? And I mean, somebody like the CQC should have been going in to check why you were seeing high levels of infection in particular areas. And of course, because they'd suspended visits, then no one was doing anything with it. It was almost like they were just collecting the information for the sake of collecting it, but not actually acting on it.
That document can come down, please. Do you think there was enough surveillance or data available on testing of domiciliary care staff?
No, that was another area I think that was very lax. There was it was bad enough that there was next to nothing happening in care homes, but actually I'd say if anything it was probably worse in domiciliary care. The information and guidance going out to domiciliary care workers was appalling in terms of what PPE they should be using, when they should be using it, when they shouldn't be using it. And testing was very lax, as my recollection, for domiciliary care workers.
Just picking up on something you've just said, would it have been then helpful if there had been more guidance specifically in relation to domiciliary care because it's so different?
Yeah, I mean, I think I said earlier, or if I didn't, I should have. It felt like they were making up the guidance on the hoof. You know, there was no real thought. You know, we'd have conversations and one day they'd say, oh, I think you can use a mask. Domiciliary care workers can use a mask for a whole day. And then we'd push back and say, well, what if they've got 10 clients in a day or 20 clients in a day? Does that make a difference? Oh, well, maybe they should only use it for 10 clients, and somebody else would come in with another suggestion. And clearly no thought had gone into this. There was no scientific backup to it. You know, nobody was saying, well, this evidence shows that if you use them for X amount of time or X number of clients. And that would never have happened in the NHS. You know, there was much clearer guidance for the NHS about when you would use PPE, what type of PPE, and they have a structure to escalate problems. If you're a domiciliary care worker, you're basically you're a lone worker. You know, most of the time, occasionally you might be with one other person. You don't see your supervisor very often. You're sent the list of clients on a phone app, and you go out and visit your clients.
Apologies to change subject again. I have two final topics I would wish to ask you about. The first is the regulatory inspection regime over the course of the pandemic. And just two questions on this, please. Was the lack of regulatory inspections something that may have put workers in homes at risk?
Oh, I'm sure it did. I mean, it seemed strange to me, and still does, that the CQC stopped going out to do inspections at a time of a pandemic. And I know the government's view at the time was red tape's a disadvantage, etc. But
could I possibly, if you can, focus on the impact it might have had on the workers?
Well, if CQC were going in and looking at homes where one PPE was locked in a cupboard and staff couldn't get it, surely they could have done something about it. If they'd gone in and seen that there was inadequate PPE, you hope they would have actually done something about that and maybe reported it back somewhere to make sure that they were getting PPE. If they were able to see that there was high levels of infections in particular care homes, then couldn't questions have been asked about that, and somebody sent in to assist the care home with looking at infection control. And none of that was happening, you know, because there was nobody going in to do the inspections or pick up on any of these particular issues.
And then the final topic, please, which is vaccination as a condition of deployment. And we know different approaches were taken to this across the UK. Do you feel that as though the trade unions were sufficiently involved in conversations such that concerns could be raised about that policy in England or the potential policy in the devolved nations?
We had huge reservations about going down the route of compulsory vaccination, and for a number of reasons, and these were not taken seriously by the government. What astonished me was it was the only time the government ever said that they could actually implement something nationally across the care sector. So whenever we'd raised anything with them about the Infection Control Fund, making it mandatory or anything else, or distribution of PPE, it was always, we can't do that because it's nothing to do with us, this is all done locally. But somehow when it came to mandatory vaccinations, they suddenly found that they could make it mandatory across the whole sector. But I think it sent out entirely the wrong message at a time when you were trying to encourage staff to stay in the sector or encourage staff back to the sector, to say this was the only sector where you would have mandatory vaccination, because they didn't introduce it in the NHS. They were only bringing it in the care sector. And many staff felt that they hadn't had it properly explained to them what vaccination would mean. They had concerns about it. There was many black and ethnic minority staff who had very serious concerns about this for a range of very good reasons.
Now, across all the topics that we've looked at, and my final question for you, does this underscore the significance of engagement with the sector and those that represent the sector, so that governments really do have a picture of what's going on the ground to influence their decisions?
Yeah, there needs to be centralised control over what's happening in the care sector, and that, I would say this, has to include representatives of the workforce. It's not a particularly well unionised workforce, but that's not to say that, we've got about 180,000 members across that sector, that unions should have a say in it, because we're able to make that direct link with people on the ground, which will often show a different story from what you might hear back from the management or the providers or the commissioners.
Thank you very much, my lady. That's all the questions I have. I understand there are some core participant questions.
Thank you.
Thank you, Ms Paisley. Ms Morris. Ms Morris is just there.
Thank you. Good afternoon, Ms McInerney. My questions are on behalf of the COVID bereaved Families for Justice UK. Now, my first topic was about regulation and oversight of the care sector. Ms Paisley's already touched upon and asked you about your views about the impact of the CQC and, in fact, Care Inspectorate Wales pausing inspections during the pandemic. I wanted to ask you more generally, please, from the perspective of your organisation, what was your overall assessment of the effectiveness of the regulatory and enforcement framework for adult social care during the pandemic?
It was very poor. The fact that they did stop the inspections was astonishing. You would think at a time of a pandemic the regulators would have stepped up rather than stepped backwards. We were astonished by this decision, it would have, I think, caused harm to the sector, both to the staff and to the patients.
Thank you. Moving forward beyond the pandemic, the inquiries heard about the independent review into the regulation of the care sector in 2024. We've heard it referred to as the DASH review, which found that after the pandemic, the overall inspections had continued at a reduced level, and said there'd been what they called a stark reduction in CQC activity between 2019 and 2023. And I think there's around half the inspections in 2023 that there had been in 2019. The inquiry heard from Miss Cridge yesterday from the CQC that there was what she called a, quote, failed transformation of the CQC after the pandemic. And she acknowledged that the CQC was still only on the road to recovering its pre-pandemic inspection levels. I want to ask you whether you agree with this section of the DASH report, please. The review concluded that poor operational performance is impacting on the CQC's ability to ensure that health and social care services provide people with safe, effective and compassionate care, negatively impacting the opportunity to improve health and social care services and, in some cases, for providers to deliver services at all. So that's the 2024 position. Do you agree with that?
I do, completely.
So does that indicate that there's still an ongoing concern?
Yes. Social care is still very much an afterthought when it comes to inspection, training, regulation, certainly in England, but it's not that much better elsewhere, but it's certainly much worse in England. So, we're slowly moving towards a situation, I think, where the current government has got a vision for a social care sector and has set up a partnership arrangement, working arrangement, but that won't necessarily impact on the inspection regime at this point in time.
Thank you. final topic connected to regulation, but this time about data. Did you consider that there was a lack of clarity in the institutional responsibility for addressing disproportionate mortality in the care sector, as well as monitoring of basic data, for example, on deaths, who died, when and why?
Yes, it's been quite hard to get detailed information, and I think there was probably a lot of under-reporting, certainly in the beginning, of what patients died from, or care, people who were in care homes, what they died from, and certainly for the staff too, that many of them would have got ill and possibly died, and it wouldn't necessarily have been recorded as COVID related.
So in terms of those receiving care and the carers themselves?
Yes.
Thank you, that's helpful. Those are my questions, thank you.
Thank you.
Thank you, my lady.
Thank you, Ms Morris. Mr Straw. Mr Straw's that way.
Thank you.
Good afternoon. I represent John's Campaign, Patients Association and Care Rights UK. Firstly, you say in your statement that Unison repeatedly raised the need for clear guidance with government, and there was much confusion with the guidance that the government produced. Now, you've already touched upon PPE guidance, but was guidance on other issues, not just PPE, unclear and confusing?
As in, what kind of other guidance did you have?
Guidance on other aspects of the response in the care sector to the pandemic, visiting, end of life, things like that.
Yes, certainly around visiting there was, I think, quite a bit of confusion. Again, that was something that would come through the hotline that we'd set up for the Unison members. That people were a bit concerned about what the advice was, for example, on visiting, and the problem always felt that the guidance that went to the care sector was very much a kind of either an afterthought, or it was done probably without much involvement from those who either commissioned, delivered the service, or those who worked in the sector.
Can you say what sort of adverse impacts that unclear and confusing guidance had on the ground?
Well, I think certainly for the workforce that the unions would represent was, one, either they couldn't get clear guidance, it wasn't available on the website in a way that was accessible to them, or didn't reflect their situation at work. And there was a lack of consistency, I think, across the care sector, that perhaps you didn't necessarily... I'm not saying it was all perfect in the NHS by any means. There was lots of issues in the NHS too, but if you think of the fragmented nature of the care service, the lack of guidance and the lack of a structure where you've got senior staff who are well trained, able to pass on clear information and guidance to the perhaps the sort of, I hate to use the term basic level, but the main level of care workers. That's always an issue in the care sector. So unless some other organisation is providing clear guidance, you can't just rely on the managers within that home or the people who are running the home, because one, there's very few of them probably, and they themselves may not be that well trained.
Okay. Slightly different topic. In paragraph 96 of your statement, you note that nothing was ever done when complaints of malpractice were reported to the CQC or the local authority. What changes should be made to ensure that an effective mechanism for responding to complaints is in place?
So again, I think it goes back to making sure that there is some sort of centralised system, or if not centralised, a recognised structure across the country where people are clear who has the key responsibility, and whether that's the local authority, whether it's the NHS, or it's a new body that's set up. There is that lack of clarity about who has the responsibility and who people are accountable to in the care sector. And I think a lot of this goes back to major structural problems within the care sector, because there isn't. If you said to somebody in a care home, if something goes wrong here, who do I complain to? A lot of people won't know, whereas you would in other organisations that provide care or health, you probably would know.
And just very briefly, you said earlier that the CQC's inspection activity was very poor and caused harm to the sector, including to patients. Can you touch upon what sort of harm it caused to patients?
Well, I think I would refer to the answer I just gave to your colleague there. The fact that the CQC weren't going in to check meant that things like high infection rates in a particular care home weren't being properly picked up and addressed. The fact that there was nobody going in to inspect and check whether there was adequate PPE provided or that staff had been trained on how to use it meant there was probably more likely to be cross-infection, with staff either not having the right PPE or not having the right training and what to do with the PPE. You're probably more likely to get infections between patients if staff are going in and out of different rooms, or if it's domiciliary care, if they're visiting people at homes. So all of that would have added to, pressure on patients and a higher risk to patients.
Okay, thank you very much.
Thank you, Mr. Straw. Ms. Weston. Which one?
It's Mr. Clark.
Oh, I'm so sorry. Yes, you don't look like Miss Weston.
Good afternoon, Ms. Weston. I asked questions on behalf of the frontline migrant health workers group on a number of topics.
I'm not sure you're...
Is that better?
That's much better. Thank you.
Great. The first topic is about the Infection Control Fund and sick pay. At paragraph 50 of your statement, you explained how many care homes refused funds from the ICF due to fears from employers that paying full sick pay to self-isolating workers would set a precedent. And I'm not going to ask to pull it up, but there's INQ000119-075, which is a series of minutes from a DHSC meeting from October 2020, noting that care providers were also refusing funds on the fear that this would set a precedent for workers. And at your paragraph 54, you described the concern on the part of providers that workers would call in sick after a heavy night. Can you give us your view on the attitude that care home providers had towards the workers at this time?
So I wouldn't like to say this was all care providers, because clearly there are some excellent care providers. So I don't mean this to be, it's not a blanket statement, but there was a sufficiently high number of providers who had a very poor attitude towards their staff. And this is basically just the tip of the iceberg. I have to say I sat through many meetings, and so did my colleagues, where this was the tone of this was something that would come across regularly, where it was, we don't want to pay sick pay because it will set a precedent. People will think they're entitled to sick pay afterwards, or we don't want to pay sick pay because they'll all basically be, taking advantage of it and going off sick even when they're not sick because suddenly we're going to pay them. And it's very much depending on the care home. It was the culture of these are people you can't trust. These are low-paid workers. We can't trust them. It was quite shocking, to be honest. In fact, very shocking that was the attitude. Even during the pandemic, that was still the attitude of some care providers.
And at your paragraph 51, you explained that Unison raised concerns about the ICF when it was launched, about the lack of mechanisms to enforce and monitor the use of how the funds were allocated. And Helen Whately MP replied saying that they were allocated on condition that it was used for infection control measures. You gave evidence earlier about the enforcement mechanisms for the ICF being insufficiently robust. Can you just help us with what you think a more robust system might have looked like?
So what we were asking for was that it be mandatory, that it be used to pay for sick pay. And that was, we were never successful in getting that. So the government came up with, I think we managed to get the word something like, I can't remember the exact wording now, something like one of the uses of it would be to pay for sick pay. But there was a list of other criteria that it could be used for. And it was clear that some care providers were taking the money but not using it to pay for sick pay. And I remember being at meetings and saying to them, is this being monitored? Are you asking questions? Who's setting the terms of reference for this? And how are you going to make sure that those who take the fund are using it appropriately? But it was considered not sufficiently important at the time, so nobody ever did that. It was never properly followed up, and there was no real mechanism to enforce it.
Thank you. My second and final topic is about the movement of workers between care settings. At your paragraph 68, you recall in a meeting in July 2020, the DHSC explained that movement of care staff between settings was one of the main reasons behind the spread of the virus. And you've given important evidence today about agency and domiciliary workers, who, of course, are a key category of workers here in terms of movement, as you've explained, because of the likelihood they'll move between multiple workplaces. Such workers often lacked an identifiable employer to raise concerns to or unionise against, and many felt unable to push back when workplaces weren't complying with relevant guidance. How do you think these kinds of factors, in terms of conditions of domiciliary workers, contributed to the spread of the virus?
Certainly the information we got back when we surveyed our black and ethnic minority workers in particular was that many of them felt afraid to raise issues and concerns that they had. The fact that so many of them do have worked for more than one employer is directly related to the fact that the pay is so poor in the sector and it's so precarious. So they would be on a zero hours contract with one employer, but they needed some specific income from another employer. Without a doubt, I'm sure this impacted adversely on patients, the fact that staff felt they had to still take on more than one job and move between them.
Thank you very much. Those are my questions.
Thank you very much, Mr. Clark. That completes the questions that we have for you. Thank you very much indeed for your help and the help of your colleagues in preparing the statement, and then you're coming along to speak to it. Thank you.
Thank you, my lady.
Very well. I shall return 10 o'clock tomorrow.
All rise.